I think, first of all, let me thank the AIOC for giving us this platform, and my sincere thanks to our chief instructor, Dr. B.P. Kashyap sir, for giving me this opportunity to be a part of this instruction course. And this is a very, very important diagnostic tool which is very underrated. It gives a lot of information, but unfortunately, because of the lack of awareness and lack of exposure, we don't use it as much as we should have done it. So I'll be talking about I'll giving you the basic introduction of this electrophysiological tests that are done, so that it makes easier to grasp and to understand the details of the tests which the other co-instructors will be talking about. So we have different procedures to examine the eye, but it is the electrophysiology which gives us the early and specific information about the condition of the eye. And the ISF is the society that standardizes tests. It is used to localize the problem in the visual pathway, because symptoms history and family history clinical examination has its own limitations. Patients with night blindness may have many other causes apart from RP. An absolutely normal looking retina may have no vision, and retinal pigment abnormality may not match the amount of visual loss, the amount of blindness that the patient has. So who are the candidates who should be investigated, who should be put to these tests? The patients with symptoms suggestive of any known neurological or other ophthalmological diseases which require confirmation of the diagnosis, like RP, Best disease, multiple sclerosis, etc. When there is unexplained visual loss, including medical legal problems and defects associated with psychiatric disturbances or mental health, mental and physical handicap. Pediatric neuroophthalmic practice, this is a very important tool where media opacities prevent other clinical examinations from establishing a diagnosis, like cataract, corneal opacity, vitreous hemorrhage, etc. And in monitoring the health of retina when the patients are receiving medications which would be retinotoxic or neurotoxic, like HCQ, ethambutol, tamoxifen, and phenothiazines, etc. In detection of the disease or carrier state of inherited visual disorders like RP and cone dystrophy, this is very useful. It provides a quantitative assessment of the progress of an eye disease and in assessment of retinal and optic nerve function following trauma. When we get the referral, if the patients are suspected to have inherited retinal degeneration, then we need to perform a full field ERG, multifocal ERG, pattern ERG. In cases of glaucoma, pattern ERG is useful. In cases of ocular siderosis, full field ERG. In cases of retinal detachment, full field ERG and VEP. VEP helps in multiple sclerosis. In inflammatory ocular diseases, full field ERG and multifocal ERG is useful. In retinal ischemic conditions like diabetic and avascular disease, retinal full field ERG and multifocal ERG is done. And in endophthalmitis, full field ERG and VEP is done. When there is a failure to read the chart with no other abnormality and visual behavior is normal, full field ERG, multifocal ERG, and pattern ERG and VEP, all these tests are useful. In post-traumatic visual impairment, the pattern ERG and multifocal ERG and VEP. In visual impairment and stress, multifocal ERG, pattern ERG, and VEP is useful. In electrophysiology, basically it records the membrane resting potential and the changes that occurs after the light stimulation. Transmembrane movements of ions in retinal cells, mainly the sodium and potassium. It makes the cells hyperpolarize, that is more negative to the extracellular space than in the dark. In ECG, actually, because the heart beats, so it does not require any outside stimulation. But in ERG, cells are at resting condition and requires light stimulation for the changes to happen at resting potential in the form of hyperpolarization. This is the list of the electrophysiology tests that we do. It is electrooculogram, scotopic ERG, photopic ERG, pattern ERG, pattern VEP, flash VEP, and multifocal ERG. Some other tests which are in the experimental stage, like ERG on-off response and S-cone ERG, multi-channel VEP, sweep VEP, and albino VEP. They are also in the pipeline. So in electrooculogram, we get to know about the RPE resting potential. In pattern ERG, it gives us the idea of gross macular function. In scotopic ERG, that is a dark adapted condition, it gives us the information of gross rod function. In photopic ERG, it gives gross cone function. In pattern VEP, the macular ganglion cells. Flash VEP tells us about the visual cortex, and multifocal ERG about the macular photoreceptors. When we have to do a number of tests, then how do we start? We should start with pattern ERG because dilatation is not required for this test, and it is done binocularly. Then we need to dilate the patient and dark adapt for about 30 minutes. Then we do scotopic ERG. Then we light adapt the patient for about 15 minutes and then do photopic ERG. We get a few waves in the ERG reading. The A wave is the negative component which comes from the photoreceptors. The B wave is a positive deflection which is caused by Muller and bipolar cells. And then we have a C wave which is a positive deflection following the B wave, and it comes from the basal portion of the RPE. We get a few oscillatory potentials which are positive wavelets on the ascending limb of the B wave, and they are originated from the amacrine cells. Again here, the A wave is the hyperpolarization of the photoreceptors. The B wave, it reflects the postsynaptic activity of Muller cells and bipolar cells. Then C wave, it comes from RPE, and D wave from bipolar cells, and there are oscillatory potentials from amacrine cells. The full field electroretinogram is a mass electrical response of the retina to photopic stimulations, photoreceptors to the inner plexiform layer. In the pattern electroretinogram, it measures the central retinal and ganglion cell function. Stimulation is done by reversing black and white checkerboard, which alternates and differentiates the optic nerve and macular function. It is recorded using a DTL electrodes, which will be discussed in detail by the next speaker. And P50 macular photoreceptors and N95 ganglion cell layers. The electrooculogram, it checks the change in the electrical potential between the cornea and the ocular fundus, outer retina, and RPE. It is recorded during successive periods of dark and light adaptation. Electrical signal is generated at visual cortex in response to visual stimulation. It assesses the integrity of visual pathway. It reflects the activity of central visual field. The multifocal electroretinogram is simultaneous recording of focal retinal responses. It offers direct objective and topographical mapping. It records the central 30 to 40 degree of retinal function. It is a cone-driven response, and fovea, parafovea, and near peripheral photopic retina function can be evaluated. The ERG is recorded by measuring the potential difference between electrodes, one of which may be a contact lens electrode. There is a reference electrodes which are applied close to the eye near the canthus, and there is a ground electrode which is applied to the forehead. This is a very, very important comprehensive chart. On the left side we have the tests, and then the refractive condition. There are some tests in which we need to give the patient a full refraction, and visual acuity is also important. In some of the tests, like in flash VEP, it is not important. In flash ERG, it's not important, but in multifocal ERG, the visual acuity is very important. Pupil dilatation is again, in some of the tests it is required, and like in pattern VIP, it is the patient does not need to be dilated. In pattern ERG also, without in undilated condition, it can be done. Then test distance also varies. In some of the tests, it is 30 centimeters. In some, it is 1 meter. And fixation is also very important. Like in full field ERG, it is very important. Multifocal ERG, it is very important. And in VEP, it's not important. So with this, I would like to finish my talk, and once again, I thank AIOC and our chief instructor for this opportunity. Thank you very much.
Thank you, Dr. Bibhuti. A very good presentation and overall view.